Hi, everybody. It is great to be in Moscow virtually, and it is my pleasure to be presenting on prognostic and predictive biomarkers in clinical trials and biomarker-driven drug development for all the young oncologists who are participating in this clinical trial workshop. My name is Dr. Abdul Rafeh Naqash. I am a medical oncologist and assistant professor of medicine at the Stephenson Cancer Center, University of Oklahoma, and I'm involved in early phase clinical trials and immunotherapy-based research. So objectives of this talk, we will be discussing what are the types of biomarkers and lay some emphasis on prognostic and predictive biomarkers. We will touch upon umbrella and basket trials. We will also talk briefly about different designs with single biomarkers, and we'll eventually end with trying to understand where we are heading with biomarker-based drug development. So the first question is, what are biomarkers? In simple terminology, a biomarker is a characteristic that is objectively measured and is evaluated as an indicator, but needs to be precise, reproducible, and has to be measured in an objective way, and helps to differentiate either normal biological state from pathological state or a pharmacological response to a specific therapeutic intervention. There are different functional definitions and types of biomarkers, as is shown in the chart here. Predictive biomarkers are defined as biomarkers that are associated with outcomes. These outcomes are linked to a particular intervention or treatment. An example of this could be tumor mutational burden in some tumor types which are treated with immunotherapy. Prognostic biomarkers, on the other hand, these are biomarkers that correlate with disease outcome, which is independent of the intervention. An example of this could be LDH, for example, in melanoma, or some of the scoring systems developed for lymphoma. Diagnostic biomarkers, on the other hand, these are usually binomial, that is positive or negative, and they help in the determination or support the diagnosis of a disease. And finally, pharmacodynamic biomarkers. These are biomarkers that confirm treatment effect by assessing biological activity, for example, ATR inhibitors, where you want to measure DNA damage response elements such as gamma H2AX or phospho-NBS in the tumor. So we will touch more upon predictive and prognostic biomarkers in the subsequent slides. There are some important regulatory definitions that need to be considered for biomarkers. One is an integral biomarker, and these are biomarkers that are used for determining patient eligibility, and these are very inherent to the design of a trial. And these need to be performed in a clear environment using an assay that has been validated and is reproducible. Integrated biomarkers, these are biomarkers that involve testing a hypothesis based on pre-existing data. These could be pharmacodynamic biomarkers. These often provide evidence of pathway activation. And finally, exploratory biomarkers, these are descriptive in nature, and these are usually assessed to generate hypotheses and are not testing a hypothesis. Usually, these are done using assays that are not validated or fit for purpose. An example of this is shown on the right, where if you're trying to design an immuno-oncology-based trial for a tumor, your integral biomarker could be, for example, PD-L1 threshold of more than 50%, where you're trying to identify patients that have a PD-L1 of more than 50% and treating them with a certain agent. And your integrated biomarker could be tumor mutational burden, because TMB, different cutoffs for TMB have been shown to have association with treatment outcomes. So once you choose these patients that are PD-L1 more than 50%, you could test a hypothesis whether these patients with TMB less than 10 or more than 10 would benefit more or less with this immuno-oncology agent that you're trying to use. And finally, exploratory signature in this trial design would be something on the lines of RNA sequencing done to assess STING pathway activation and trying to generate a hypothesis whether STING high tumors within these subsets benefit more with this immuno-oncology agent. So prognostic versus predictive biomarkers, it's important to understand what they mean. Prognostic, as is shown on the left, markers, these are markers that help us in understanding long-term outcomes, which are either unrelated to or with a standard treatment. While as predictive biomarkers, these help us in assessing outcomes that are related to the treatment. To understand this a little better, I've included some graphs on the right, and on the left panel, you see biomarker negative groups. On the right panel, you see biomarker positive groups. So in the first instance, the biomarker positive patients have better survival than the biomarker negative patients. In this case, the better survival being represented on the y-axis, where the tail of the curve is higher for the biomarker positive group versus the biomarker negative group. On the other side, the treatment effect that is understood based on the hazard ratio difference here, with, comparing the blue to the yellow dotted line. So the treatment effect is the same for both biomarker positive group and the negative group, while as the survival is different or higher in the biomarker positive group, and this is a prognostic only marker. On the other side, in panel B, you see this biomarker is purely predictive, and the treatment effect, as you see, is only in the biomarker positive subgroup. There's no treatment effect in the biomarker negative group. So this is purely predictive biomarker. And panel C is a biomarker which is both predictive and prognostic. Predictive because the treatment effect is significantly more in the biomarker positive group compared to the biomarker negative group, based on the hazard ratio differences, estimated hazard ratio differences for the blue and the yellow dotted lines. And also the tail of the curve or survival is higher for the biomarker positive group than the biomarker negative. So this is both prognostic and predictive. And again, a 4-panel slide to further elucidate this. Panel A shows benefit that is related to the treatment and has nothing to do with the biomarker. Panel B shows similar independent treatment benefit that is seen in both biomarker positive and biomarker negative, but the tail of the curve, that is survival, is higher in the biomarker positive group, which means that this is a purely prognostic biomarker. Panel C shows treatment that is beneficial only in the biomarker positive group. So this is a purely predictive biomarker. And panel D has 3 things going on. One, comparing the red dotted with the red solid line, there's no treatment benefit in the biomarker negative group. The second thing that is happening is within the biomarker positive group, their benefit is more of a treatment. And the third thing is the survival, again, is higher for biomarker positive group versus the biomarker negative group, and is irrespective of the treatment that you have given. So this is a pure, both prognostic and a predictive biomarker. Some examples to further elaborate this. For a prognostic biomarker, this is a representation of the Cleopatra trial evaluating pertuzumab, trastuzumab, docetaxel versus placebo, trastuzumab, docetaxel, where they tried to assess whether PI3K mutation was prognostic or predictive. And here was prognostic because women with the tumors that were harboring PI3K mutation had worse PFS or progression-free survival, and this was regardless of the treatment group. So as you see here, the difference between the placebo, trastuzumab, and docetaxel wild type, which is represented, and the wild type here being PI3K wild type, both the wild types are represented in the dotted yellow and the dotted red. So the difference between the dotted red, yellow and the dotted red, which is the wild type PI3K group, is similar to the difference that you see in the solid yellow and the solid blue, which is the PI3K mutant. And this suggests that this is a purely prognostic biomarker. For a predictive biomarker, an example is this association of progression-free survival with tumor mutational burden from 3 trials involving atezolizumab, that is the oak poplar and the IMvigor211. As you see in the left panel, atezolizumab, in the blue line, TMB more than 16 mutations per megabase is associated with better progression-free survival, higher PFS compared with TMB less than 16. But on the right, in the chemotherapy cohort, TMB less than 16 and more than 16 do not seem to have any significant difference. So this is a predictive biomarker here. And as an explanation, again, I've drawn on the extreme right, the atezolizumab, the chemo tumor mutational burden low arm in gray, and then you see another curve for the atezo TMB low, not much of a difference for TMB low with atezo and chemotherapy. The third line being the chemotherapy given in TMB high, and the fourth line, the blue solid line being atezo in tumor mutational burden high patients, showing significant survival difference compared to the other 3 arms. So this is an example of a predictive biomarker. So some other things that we need to understand in predictive biomarkers is qualitative and quantitative interaction. So on the left panel, you see a qualitative interaction where some patients benefit and some don't. And the treatment effect varies basically by the subgroup. That is, some are positive and some are negative. Example here is the MYSTIC trial where durvalumab and tremelimumab seem to benefit on the left panel with the survival curves that you see here. In the first figure, you see the chemotherapy seems to benefit patients that have a TMB of less than 16, while as on the right, the durva-tremi combination seems to benefit patients that have TMB more than 16. So this is a qualitative interaction because the threshold of the biomarker seems to determine which patients benefit more with what type of therapy. And on the right, there's an example of the KEYNOTE-042 trial, which was evaluating pembrolizumab in patients with non-small cell lung cancer. This is an example of a quantitative interaction where all patients benefit, and but the degree of benefit differs. So the treatment effect varies in magnitude by the subgroup, but it's always in the same direction as you see here. Maximum benefit seen in patients with more than 50%, slightly lesser, but again, positive benefit seen in patients with more than 20%, and even lesser benefit in more than 1%, but it still seems to be in the same positive direction. So what is the era of precision medicine as we're talking about biomarker-driven drug development? So in the past few decades, we know that clinical trials have experienced a major paradigm shift. And one reason for this shift is we have started to incorporate ever-growing tumor biomarker information, and we're evaluating biomarker-defined patient cohorts in our trials. But there are some key considerations that need to be kept in mind when designing and conducting biomarker-driven clinical trials. Some of the challenges and key considerations I've highlighted here, for example, tumor heterogeneity is a major one where one biopsy may not necessarily represent what is going on in the entire tumor. So understanding what mutations could be driver mutations versus what mutations could be passenger. And sometimes this is context dependent. For example, KRAS G12C inhibitors work better in lung cancer versus colon cancer. And some of these considerations are important to understand whether a certain mutation could be druggable in a certain tumor type. So, the other issue is absence of a clear-cut biomarker cutoff, and TMB is an excellent example of this, where when you set certain threshold for a cutoff for TMB, you might erroneously exclude patients that may benefit because they do not fall within that cutoff. The third consideration could be, is there enough preclinical proof of mechanism to understand target inhibition? So you're treating patients with a certain drug, but if there's no extensive pharmacodynamic studies done to identify a dose that leads to target inhibition, you may not be treating patients with the appropriate dose that could lead to sufficient target modulation and eventually anti-tumor activity. And then understanding compensatory mechanisms that start occurring in the tumor microenvironment, because the tumor microenvironment, as you know, is very dynamic. Things keep changing. It is not a static phenomenon. And these lead to certain pathways being activated that could result in the therapy being circumvented. And finally, incorporating biomarkers or precision medicine does come at a financial cost and leads to financial toxicity for our patients and the caregivers. This is a slide where I wanted to highlight tumor heterogeneity and selection pressure. And this is an excellent example of the tree, trunk, and branch hypothesis, where the truncal events could be potential drivers. So the trunk harbors the founding driver mutations of a cancer in every subclone and every region of the tumor. However, the branches represent different geographically separated regions of the tumor where you have different subclones that might be coming up. An example here is the difference between the palm tree and the baobab tree here, where potentially increasing the number of branches or more subclones could lead to more treatment failure. So basically highlighting the fact that one biopsy may not necessarily represent the entire characteristics of the tumor. And then there's the aspect of these subclones becoming dominant or becoming drivers under selection pressure. An example on the right that I've highlighted is a glioblastoma patient where treatment with temozolomide, for example, here, led to mutations in CDKN2A and RB1 in separate subclones, both of which led to subclonal expansion, showing that in certain situations, the therapy in itself can shape the evolutionary trajectory of a tumor. So biomarker development process is a very complex process. It is not a one and done process, as many of us understand. And what we need to understand more importantly is that the drug development and the biomarker process validation especially should ideally occur in parallel. So the analytical and the pre-analytical validation in biomarker development are especially very important. And in the analytical validation side, it is crucial that biomarkers are scientifically and technically validated with a significant degree of rigor. And the analytical validation especially involves assessing the appropriate performance criteria of the biomarker, including reproducibility, robustness, accuracy, variability. All those factors need to be considered before a biomarker is taken into clinical validation. So next, we'll try to touch upon some of the conceptual understandings of designs that involve a single integral biomarker. And some of these are currently being used in the trials that many of us have come across. So first is a biomarker enrichment design, as you see here in the schema on the left. So this enrichment design only enrolls patients that are biomarker positive and should be considered when there's a strong rationale and evidence that this treatment effect is confined within that potential biomarker. An example of this I've highlighted here is the Keynote-024 trial evaluating pembrolizumab single agent in PD-L1 more than 50% in non-small cell lung cancer. So here you see that the PD-L1 expression of more than 50% was used as an enrichment biomarker or selection biomarker. And after screening close to 1,900 patients, around 500 or so had PD-L1 more than 50%, and only 300 of those were randomized. So 300 being 15% of 15% of the population that was initially screened. It was ultimately randomized, and we did see that PD-L1 more than 50% improved survival for non-small cell lung cancer significantly. So this is an example of a biomarker enrichment design. So the next is a biomarker stratified design, which is shown on the schema on the left. And here, what you basically do is we randomly assign both the biomarker positive and the negative groups to the treatment under investigation. It usually applies when there's a strong evidence suggesting that the biomarker positive group is predictive with respect to the treatment. And then there's two major substratifications of this. One is when you're testing biomarker in a biomarker positive group and you achieve a significant level of, result, then you subsequently test it in the biomarker negative group. And based on what you observe there, you either recommend or don't recommend the treatment for the biomarker negative group. And the other one, which is shown in panel B on the right, which is a little bit of a problem, but is done, we see a bunch of trials in the immuno-oncology space using this approach, is a biomarker overall design, also called the overall population design, where a biomarker positive subgroup is initially tested using significant level of alpha. And if the results are positive, then it's tested in the overall population. And I've highlighted some examples here. But the problem with this overall population design for the biomarker stratified assessment is, as I've shown here in an example, the problem here is that if a biomarker is positive and is only suggesting that the treatment effect is only in the biomarker positive group, this can erroneously lead to an assessment that we should suggest that the treatment is positive in the entire group. So as an example here, hypothetically, as you see on the left, if you're testing an immuno-oncology agent, for example, in CPS score of more than 1 and getting a significant result, and then subsequently testing in overall population and it approaches significance, you might say that, well, the biomarker is predictive of this treatment is beneficial for the entire population because the confidence interval did not cross 1 or the hazard ratio was significant, even though it's 0.91. But what we need to understand is most of the benefit here might actually be driven by, for example, the CPS score of more than 20, where the hazard ratio is 0.58. So the benefit that you see in the overall population might actually be the hidden benefit that is driven by patients that have CPS of more than 20. And what this leads to is it leads to an overall observed positive treatment effect in the overall population. So, and I'll give you an example of this. The Keynote 42 trial that evaluated pembrolizumab in versus chemotherapy in metastatic non-small cell lung cancer, which involved sequentially testing PD-L1 tumor proportion score, more than 50%, 20%, and 1%. And the conclusion in that trial was that pembrolizumab should be recommended for all the patients with TPS more than 1% because of hazard ratio of 0.92 in the TPS of 1 to 49. So the Food and Drug Administration of the United States obviously approved it, but the European Medical Agency declined to approve it, which I think is probably appropriate based on the fact that most of the treatment benefit in that trial for the 1 to 49 for the overall population was probably driven by more than 50% of TPS. And one approach to mitigate some of these issues is to use a sequential biomarker stratified design, which where you test individual populations for the biomarker that you're trying to say has strong predictive value with the treatment. So which this sort of an approach will allow independent assessment of the treatment effect in each biomarker subgroup, and could also potentially decrease the overall number of patients that you need for the trial. And I think this is a good article that was published from some people at the NIH and CI in Journal of National Cancer Institute in 2021 that you should probably try to take a look at. The third design is a biomarker strategy design, as is highlighted here, and this involves making comparisons between two strategies, one which uses biomarker information to inform treatment approach and the other that does not. An example of this is this trial of lung cancer that was published in 2006 in JCO, where the control, where ERCC1 expression was used to customize cisplatin in non-small cell lung cancer. So the control arm is getting docetaxel cisplatin, and the biomarker-driven arm with the low ERCC expression is getting cisplatin docetaxel, and the high ERCC expression is getting docetaxel gemcitabine. So the primary objective of this sort of a design is to evaluate whether the biomarker-based treatment assignment strategy is more effective than the non-biomarker-based treatment assignment strategy. The last biomarker design that I wanted to highlight here is biomarker-directed design, which only randomizes the biomarker-defined subgroup, where basically the biomarker's clinical utility in directing treatment decisions remains unclear. Meanwhile, the other two, for example, here, the other two biomarker-defined subgroups are treated deterministically. An example of this is the Taylor-X study that I've highlighted on the right, which involved assigning individualized options for patients with breast cancer with tamoxifen, and based on a recurrent gene score, 21 gene score, oncotype DX score, they were classified as intermediate, high, or low. And here, the design is being, the biomarker directed design is being used for this intermediate arm that is being randomized to receive hormonal therapy with or without chemotherapy. And the low risk patients here, for example, receive hormonal therapy alone, standard of care, and the high risk also receive chemotherapy with hormonal therapy respectively. But the intermediate group is where the biomarker directed design is being used to understand whether a biomarker can be used to de-escalate treatment in this subgroup. So one of the trials, as an example, that I was part of at the NCI was this pharmacodynamics-driven trial where we were trying to assess PD-based biomarkers for a combination of immunotherapy with different chemotherapeutic agents, different chemotherapy arms such as gemcitabine, doxorubicin, capecitabine, carboplatin, paclitaxel. So patients could either get single-agent immunotherapy if they had never received immunotherapy before, and this was tumor agnostic, or they could receive a combination of chemotherapy with immunotherapy if they had received immunotherapy before. And one of the most important aspects that was being evaluated is immunogenicity or tumor microenvironment modulation by the chemotherapies before immunotherapy was initiated, and the degree of the effect of these chemotherapies on tumor microenvironment modulation, which has not been studied well today. So if you have trials or trial samples that have already been conducted, whether they're negative or positive, you should try to use those samples to conduct some of these analyses, necessarily not all of them, to inform future trial design. So where would we be heading with this sort of an approach? So if you have, as I mentioned, current trial that are positive or negative, use this multi-omics integrated analysis approach from previous samples, and that could in turn help inform future clinical trial designs to improve the drug development process. And this is an example of a bedside to bench and a back approach, where what you've done in the past informs what you do in the future. And this will help us to shift away from this compound to trial approach to a more reasonable biology to trial approach for a patient-centered drug development process. So in the end, how do we use this biomarker approach to select rational and personalized therapies? Well, you need to take the patient into account. As you see here, you need to take the genomics, transcriptomics, proteomics, epigenomics, and then we need to stratify patients based on biomarker mechanism-specific biomarkers, and then eventually treat based on mechanism-specific treatments. And the other category could be sub-classifying patients based on immune escape mechanisms in individual patients, and then using biomarkers to define patients with certain immune evasion mechanisms that might be more potentially more susceptible to certain treatments than to some other treatments. So again, this is an individualized, personalized approach of using all the translational data to inform future clinical trial design. So in the end, I would like to thank the meeting organizers for inviting me. I've shown here in the picture my previous team that I used to work with at the NCI Developmental Therapeutics Division of Cancer Treatment Diagnosis, and on the right, my oncology fellowship team a few years back at East Carolina University, North Carolina. I would sincerely like to thank the meeting organizers for inviting me, and my colleague Alex Ticketnow for suggesting my name to present this talk. And obviously acknowledgements, I'd like to highlight some of the agencies that have funded some of my work, and especially like to highlight the Society of Immunotherapy of Cancer. If you, as a young investigator, whether you're an MD, MD, PhD, or PhD, you should definitely consider joining the Society of Immunotherapy of Cancer. I know Alexei is one of the early career scientist members, and I am as well. And there's a lot of absolutely great opportunities that SITC provides for early career investigators, which have had a lot of meaning to what I have done and will continue to do in the future. Thank you once again, and appreciate everybody's time.